Good evening, everybody in the MENA region and around the world. We are happy to present to you the grand round for the cerebrovascular stroke. Today, we are honored to have with us Professor Coutts. She is professor of Calgary Stroke Program, Department of Clinical Neuroscience, Radiology, and Community Health Sciences, and University of Calgary Foothills. Dr. Coutts had her undergraduate degree from the University of Edinburgh in 1997 and then took general medical training at Glasgow Royal Infirmary. She also had, during her stroke program, completed a postgraduate research degree on modern image in its role in prediction and outcome after stroke and TIA. Her research interests include the use of acute imaging in triage and treatment of stroke and TIA patients. Dr. Coutts has received a number of awards for her work, including the New Investigator Award from the American Stroke Association and others. She is the first recipient of the Heart and Stroke Foundation of Canada Distinguished Clinician Scientist Award. You are welcome with us, Professor Coutts, and now she could start the presentation, please.
Yeah, so I'm Shelagh Coutts. I'm a stroke neurologist in Calgary, and as alluded to, my interests are in TIA and minor stroke and diagnosis and treatment. My disclosures are mostly grant funding for my clinical trials, but I do have tenecteplase funded for my Tempo 2 trial by Boehringer Ingelheim. So I'm going to look at briefly antiplatelet therapy, which is, I think you really have two options for minor stroke. Essentially, you have antiplatelet therapy, and in a few cases, you have the options for thrombolysis. And I hope I'll give you my idea of how I approach this. And I think it's a very variable thing about how you feel about a patient. Some of it is science-based, and some of it will be based on the last case you treated, unfortunately. So there's a lack of evidence in this area. So I'm going to talk a bit about antiplatelet agents, thrombolysis, and then EVT. And these are the three main options you have. I'm presuming that you will use statins, blood pressure treatment, etc. And I'm not going to talk about that. I'm briefly going to talk about dual antiplatelet therapy because I think this will be the vast majority of what you do for a minor stroke patient. Certainly in my practice, that is mostly what happens. So POINT was the landmark trial. There was CHANCE in China, but certainly the one that has changed worldwide practice was POINT. This was minor stroke, defined as an NIH of 3 or less. And we may talk about this later, but how you define minor stroke is really a variable. In some ways, we have to use numbers because otherwise it's hard and it requires judgment, and numbers are much more hard. And so that's what POINT did. High risk TIA at the other end of the spectrum. And these are just TIA and minor stroke are just one end of a continuum of stroke from my perspective. And I don't really consider TIA or minor stroke any different. They're just at one end of a mild spectrum. They had to be adults. Importantly, for most trials now, no upper age limit. We certainly should never be excluding elderly from trials now. Patients needed treated within 12 hours of onset, and essentially they were looking for real TIAs. The only main thing that kind of made the interpretability a little bit difficult was you couldn't be doing a carotid endarterectomy, and that kind of perhaps limits some of the use of this, because in some ways they're the group that had the most to gain from dual antiplatelet therapy or probably large artery disease. So they looked at aspirin plus Plavix or clopidogrel, and being the generic name, for 90 days. They gave a big loading dose, so 600 milligrams of clopidogrel. Essentially, there was clearly benefit of the composite outcomes, so ischemic stroke, MI, death from other ischemic vascular causes. This was clearly statistically significant. The one comment I'll make is that what they didn't look at progression versus recurrence here. And so we don't know if there was a difference in preventing recurrence or versus, for example, the progression of a lacunar stroke. So we don't know that. But as you can see, it certainly reduced recurrent ischemic stroke here. There was, however, a small increase in hemorrhage. And this was often non-intracranial hemorrhage. So this is the Kaplan-Meier curves. As you see in the top one, you see clopidogrel plus aspirin, reduced risk early, and most of the benefit is very early here, so within the first few days. And then as you see, the risk of hemorrhage in the lower graph here is constant. There is no stopping the risk of hemorrhage that's increased with the addition of clopidogrel. And so most of the events were early, hemorrhagic events continued to happen. The other interesting thing, though, was there was no prevention of disability seen overall in point. And we'll come to that. So, and I think that has relevance to deciding as well about whether you're going to thrombolize somebody. Dual antiplatelet therapy is not preventing disability likely from the presenting event. It's likely preventing recurrent events. And so what about minor stroke thrombolysis? I think if you take an average population, most of us are not thrombolizing every single patient that comes through the door. Most of us will use some sort of clinical or judgment, whether that's a sort of sense of how badly effective they are. The feeling is they're too good to treat. The problem is that that's not always the case. And it's a clear balancing act between harm and benefit. And I think this is a nuanced discussion, both with the patient and in your own head. Because if somebody comes in and they're globally aphasic and they're hemiplegic, you really have very little to lose. You can give a treatment that has hopefully not a high risk of a bad thing happening, but you know the outcome is almost certainly going to be bad if you do nothing. Whereas in a minor stroke population, many people do well. And so this is the problem, is that we don't really know exactly how high the risk is in minor stroke. And I had a patient recently who was randomized in my Tempo 2 trial. So this was a minor stroke thrombolysis trial. He got control. He got basically aspirin and Plavix, and he ended up with a lower motor neuron facial palsy. That was his only deficit. He had some cosmetic issues, but otherwise actually was functionally completely normal. And he was a highly educated man. And so I sat with him and we talked about it. And I said, so what risk of death would you have taken to not have what you have now? And his answer was none. And so it's when you're in the thick of it, it's a very nuanced conversation. The issue is that stroke trials have struggled to have positive trials over the years. And so we look for high risk groups. And so minor stroke patients were really not included in most of the trials. This is the total number of patients before we get to PRISMS, but only 10% of patients, including in the thrombolysis trials, were of a minor stroke population. So in this case, it was 0 to 4 was highly defined minor stroke, but a smattering in all of the studies. Most of the most patients in any of the trials were IST3, who set out to look for minor stroke as one of their subgroups that it wasn't clear what to do. So this is the pooled data from that same those studies added together, and this is the crux of the issue. So they looked at MRS-01, which I think should be the main outcome for a minor stroke, because the problem is that an MRS of 2 is this chronic minor disability, and that's what we're trying to prevent here. Most minor strokes do not end up with an MRS of 4. They just have, they may not be able to drive again, they may not be able to work again, but they can do much of their life. And so it's a nuanced conversation here. So MRS-01 benefit, there was an almost 10% benefit in the pooled trials, but there was a 3.7% increased risk of death or almost death, so an MRS of 5.6. And so I don't think this is clear. I think as an individual patient, I don't really want to take a 4% risk of death with my cortical hand, for example. And so it's a difficult, based on this information, to know what to do. And so reasonably, PRISMS went ahead, and this was Pooja Khatri's study published in JAMA a couple of years ago. And this was a phase 3 randomized controlled trial sponsored by Genentech, adults NIH of 0 to 5, they had a little bit of a complicated definition of minor stroke. So you had to somehow assess them in a merge and decide that they were non-disabled using a Rankin. And that is hard. Knowing what somebody can and can't do while they're lying in a hospital bed, having not tried to do anything, is tough. They also had to treat everybody within 3 hours from onset, because in the United States, technically TPA can't be given out to 4.5 hours like it is in most of the rest of the world. So that means, though, that the patient basically had to be in a CT scanner 2 hours from onset with a minor stroke, so that you could then consent the patient and get drug in. And so that in itself is probably one of the issues they struggled to recruit. You also only needed a non-contrast CT. I personally don't believe we should be treating anybody in this day and age with an acute stroke without having a CT angiogram at least. So then they randomized to TPA versus a placebo. Patients got acute aspirin if they were in the non-TPA arm. Primary outcome was 0-1. Again, this is the appropriate outcome, I believe, for a minor stroke population. They enrolled just over 300 patients. The trial was terminated early due to a lack of recruitment. It was not the investigators, it was the sponsor decided things were taking too long. And this is the baseline characteristics. And I think it shows you a few things. One is that patients were relatively mild. Patients are also old, not as old as you would see perhaps in an EVT trial. They actually did quite well at getting the percentage of male to female. And then baseline score, again, showing that people do consider an NIH of up to 5 can be minor depending on what you see. There's some things here that are fascinating to me. And this also was reflected in the NORTES study when they looked at TNK versus TPA, which is that up to 14% of patients turned out to be a mimic. And I really find this fascinating. I always say that if I get a report card at the end of the year and you told me that almost 15% of my patients I treated were actually mimics, I think I should probably get a failing grade. And we all treat mimics from time to time, but I hope it's not 15% of my thrombolysis cases. And this is the problem with a non-contrast CT. It's, we need to be fast treating patients, but we need to be accurate as well. And so I think this to me shows that you need a CT angiogram. And then patients are, they're both right and left hemisphere. This is the main outcome here, and 3% risk of hemorrhage in the TPA arm. So the risk is probably lower than in major stroke, but the risk of hemorrhage is real, and it's low. And one of the problems with a single low digits risk of hemorrhage, it means that many physicians will never have seen one. So if you have a low NIH and thrombolysis hemorrhage, you remember it. And I can tell you I've had one, and the patient died, and he had an NIH of 2 or 3 when he came in, and you feel very bad. It's a very different feeling than if somebody came in with an NIH of 25. And so what it means is that it's unlikely you'll get a second statistically, unless you're very unlucky. So I think just remember there is a risk, it's real. They also did not find any suggestion of benefit. It was obviously shut down early. And so they did do some extrapolation, exploratory analysis that even a 6% treatment effect was very unlikely as they completed the trial. So certainly my interpretation of the PRISMS result is that all minor strokes should not be getting thrombolized. Now that doesn't mean there are some that shouldn't be, there probably are some that should be, but not every single minor stroke coming in the door should not be thrombolized, is certainly my opinion. The question that we don't fully know the answer is exactly what the risk of hemorrhage is. This is the data that we have. So this was the NIHSS trial, 2.3% risk of hemorrhage. Cases was our Canadian registry, had a 2.6 rate of hemorrhage. IST3 was 3%, and PRISMS is just over 3. So it certainly looks like we're in that ballpark of 2 to 3%. So what does this mean? This means that this is a tough decision, because many people on this call will never have seen a single intracranial hemorrhage from a minor stroke thrombolysis. So that means you think it's safe. It also means that even if you've had one, it's going to take you a decade to see a second one, depending on how often you work and luck and all those things. So this is a carefully thought about decision in every case. If we jump to other things, what about EVT on top of thrombolysis? We don't know is really the bottom line here. There were only 14 patients included in the Hermes pooled data from the EVT trials that had an NIH of 0 to 5. And so this is recent work from one of our former fellows, Nagara Shtagi, who's in Miami, and they looked at the Florida Puerto Rico Stroke Registry and looked at the trends over time and the proportion of patients treated with an NIH of 0 to 5. Now, this is the US, where they have been more aggressive than certainly we are in Canada with the lower NIH and EVT. So 11% of their registry were treated with a low NIH. They had a 4% symptomatic hemorrhage rate. So again, not zero. They had a 5% in-hospital mortality in the minor stroke population. And then only 76% of patients were discharged home, which means that on average, you probably think your patients did well, but a few of them have died, a few of them had hemorrhages, and almost 25% were needing some sort of rehab. So again, it's just showing that we don't fully understand the minor stroke patterns and exactly what's going on. And I agree with the statement that we do need randomized controlled trials for EVT as well. And then the crux of the matter is, like, if I obviously talk to my Aunt Gael weekly, and he'll tell you that almost everybody should get EVT. Is it safe? Well, mostly is the answer. There's about a 1.6% risk of vessel perforation, which clearly is very bad when it happens. Symptomatic hemorrhage happens, SIH, dissection, lots of things can happen. Most of them are mild and unimportant, apart from the really bad ones. And that's why I think it's important that we understand the actual efficacy. This is just showing the trends over time in Miami, showing that minor stroke has picked up over the last few years. It would be interesting to see what the last couple of years are like, because I suspect people are now realizing that maybe we should be thinking about it and not every patient should be getting EVT. We clearly have community equipoise for the treatment of minor stroke. Some centers treat all, some treat none, some use imaging. Some patients have such a good prognosis that the risk of any hemorrhage is not worth taking. But there are clearly groups that are going to do worse. For example, patients who we can see occlusions in. So this is why we have the Tempo 2 trial running. This is a minor stroke with an intracranial occlusion, randomized to thrombolysis with tenecteplase versus non-thrombolytic standard of care. So for the most part, that's aspirin and Plavix, looking at disability. So essentially adults, NIH 0 to 5, and any intracranial occlusion, randomized to TNK versus control. Just to show, this is the last time I had a look at the location of occlusions. There's a whole smattering all over the place. We have a lot of patients who actually have an M1 occlusion that are randomized, and we can talk about that. Patients who come in with an NIH of 2 who have an M1 occlusion are not the same as somebody with an M1 occlusion who have an NIH of 20. And I think you need to think about that. We certainly would randomize them in Tempo, and we would watch them very carefully and go to rescue EVT if we needed to. And I certainly don't think every single case needs EVT, but that's my personal opinion. So just to give you an example, this was actually a patient in Tempo 2 who had a terminal ICA occlusion, had a previous stroke, as you can see in the right MCA, presented with very minor symptoms with a terminal ICA clot, so a large clot, NIH of only 2, had some very minimal, perhaps some early ischemic changes here. Always hard to call with a little bit of an old stroke there. Patient was randomized to tenecteplase, and completely recanalized and went back to normal. And so, it's one of these things that large clots can open up with thrombolysis. They don't always, and they certainly have less opportunity to open up than more distal are more likely to open up with thrombolysis overall. But this is a good example of exactly what we want to do, which is early recanalization and early benefit in this case. So I would just overall end with the idea that minor stroke patients are this population that have something to lose. And that's the difficulty in making your decision. Your treatments have to be very safe because you don't want to make them worse. I believe that this is a population that thrombolysis will continue to be more available. It is more benefit because distal occlusions will, unless our technology changes dramatically, you're never going to be looking after M3 occlusions routinely with EVT. With a minor stroke, you're unlikely to get bypassed to your major tertiary center. I watch these patients very carefully. I admit them to our main acute unit, and we're ready to do rescue EVT if we need to. And so what do? I don't treat all minor strokes with thrombolysis. I try and clinically assess for disability. If they're clearly disabled at that moment in the emergency department, I will thrombolyze them. So, an NIHSS but with a field cut means they can't drive under Canadian law. So if you drive, I would thrombolyze you. If you were a 90-year-old and you already stopped driving, I might not thrombolyze that same patient. And so there is there's thought involved in this. This is not a recipe book. This involves careful clinical decision-making. If they're not disabled, I would give dual antiplatelet therapy for 21 days. Or if you're in a center which has trials that are options, I randomize every patient eligible to Tempo 2. Or eventually we will have endo low, which is for minor stroke with EVT as well. And I'm going to stop there, and that's my email if anybody has any questions, and I think we have a Q&A session later.